So I thought just to kind of frame the discussion, it might be helpful to just, present an emblematic case. It's made up, but, a typical patient we might see in our clinic. And then I just have a few slides, relevant to the subject that maybe will open up the discussion. So, let's say you have a 70-year-old patient who's referred for progressive pancytopenia and fatigue. He is independent of his ADLs and IADLs, but he's pretty sedentary and has never been somebody who exercises regularly. He's a retired banker. There's no family history of hematolymphoid cancers or other relevant cancers. He does have 3 younger siblings. His comorbidities include coronary artery disease with a stent 3 years ago, hypertension, and type 2 diabetes managed with oral hypoglycemics. And he does, his major thing that impacts him is OA of his back and his hip, which is why he also does little walking. He's on metformin, atorvastatin, acetaminophen, and aspirin. And, and his physical exam is really just remarkable for elevated BMI. He's not yet obese, but he's on the cusp of what you would call obese. But the rest of his exam is unremarkable. And he has a moderate anemia and macrocytosis. He's leukopenic and neutropenic, but not dangerously so, with a neutrophil of 1.2, and his platelets are 90, and his LDH is a little elevated. Next slide. So you do a bone marrow aspirin and biopsy. You've ruled out all reversible causes of his cytopenias, and then proceed with a bone marrow aspirin and biopsy. And he has myelodysplastic syndrome with bilineage dysplasia. So he's MDS MLD. His blasts are 4%. He has no ring sideroblasts. He's got early reticulin fibrosis. His cytogenetics are intermediate with trisomy 8 and del20q. And so when you calculate his IPSS-R score, it's 4.5, which is the upper cusp of what we considered an intermediate risk disease. So based on the IPSS-R, his median overall survival would be considered 3 years. This very difficult to interpret statistic, which is the time for a quarter of these patients to develop AML is 3 years. Next slide. So, it's always difficult to know what to do with intermediate risk patients. And in the last few years, it seems that there seems to be a way of perhaps dichotomizing risk scores, at least using the IPSS-R, and predicting who's going to do well and who's not going to do well. We first, had a hint of this from Dr. Feilstocker's paper in Blood in 2016, where this sort of threshold of less than 3.5 or equal to 3.5 seems to separate the good actors from the bad actors with regards to survival. And that's been replicated in a separate group of patients from Spain with 4,000 patients included who had an IPSS-R. And they defined high risk as somebody who has a survival of less than 30 months. And they found, again, that this cut point of 3.5 has an accuracy of 75% to predict who's going to live less than 30 months. And in their model, 65% of intermediate risk patients are upgraded to what's considered high risk. So I'm just going to pause right here and ask my co-members, physicians, clinical physicians who treat MDS, whether or not they themselves agree that 3.5 is something that they pay attention to. This cut point of 3.5 is something they pay attention to in the clinic.
Okay, I can answer to that. So in addition to an IPSS-R based risk score, I would first look at the other factors of the patient. So in this case, the comorbidities. And so whether we should exclude intensive approaches with associated prolonged hypoplasias or pancytopenias and bone marrow transplantation or stem cell transplantation. And if you look at this patient, this is also so the cutoff point in the intermediate risk group does not take into consideration these factors in this patient. So I think that should be taken care of. The second point is whether the patient is transfusion dependent, yes or no, because that's a prognostic factor independent, which is not well covered by the IPSS-R. And also the opinion of the patient themselves. He, of course, he is asking advice, but he may have his opinion after our advice.
His goals, what his goals are, I completely agree. And Theo, would you say that based on his comorbidities, and his sort of borderline obesity, that he would not be a candidate for allogeneic transplant?
I would be very careful, that's for sure. Because he has general cardiovascular disease. So I would like to know the status of his main arteries and so on.
Okay.
And his heart, of course.
Okay, thank you. I agree with you. So Silvia and Yasushi, do you guys have anything to add before we go on to talk about mutations, of course?
Okay. Rena, sorry, go ahead. Oh, sorry. Go ahead. And just to confirm, we also use the 3.5 threshold, and we take in account, as Theo just said, the comorbidities, especially the disease-related factors.
Okay, so I agree with you in terms of the risk assessment of MDS itself. I think his MDS is almost high risk MDS, but as Theo and Silvia said, considering his background, his personal background, cardiovascular diseases and diabetes, I didn't notice his renal function or liver function well.
Let's say they're normal. Let's say they're normal.
Okay. How about thinking about the atherosclerosis situation? I don't think he's at least a good candidate for allogenic transplantation. And his age is 70 years old. That's the almost upper limit of general allogenic transplant. So I do not think allo transplant as a front treatment for him.
Okay, great. Great. Can we go on to the next slide? So I sort of summarized, everything that's over the years has been sort of listed as an attenuating or additional information prognostic factor in addition to the disease-related IPSS-R or IPSS that have been shown to add value to prognosis. We're going to talk more about mutation number and mutation type in a second, but as Theo alluded to, transfusion dependence and density, of course, is a major refining prognostic factor for any given risk score, particularly lower risk patients. In the past, beta-2 microglobulin and CRP have been listed as prognostic. I'm not sure anyone, it's certainly been shown, but certain flow cytometry scores, the more sort of deranged or aberrant markers being expressed has been associated with prognosis. I personally, I don't use that in my day-to-day practice, mainly because there is no one validated score, but it'd be interesting to hear if any of my co-investigators pay attention to it in their day-to-day practice. Serum albumin has been shown to add value, ferritin, iron saturation. I think Theo, you presented a paper from the ELN MDS registry that showed that the speed of decline in the platelet count is also prognostic. LDH has been shown to be prognostic. We know that the receipt of iron chelation therapy is associated with improved overall survival. We don't know whether or not that's correlation or causality with regards to the fitness to receive iron chelation therapy, although our group in Canada showed that even controlling for comorbidity and frailty and disability, that the ICT does add value. Bone marrow fibrosis has been shown to be a prognostic marker, and I guess I'd be interested to hear if anyone pays attention to that and worries when they see fibrosis in a higher risk MDS patient. And then, of course, the ability to receive an allo transplant is going to impact whether or not the disease is curable or not. And then, of course, there's lots of patient-related factors that have been shown to add independent prognostic value. We and others, like the MDS registry in Canada, and then Fabio Afficaci has published extensively about the impact of fatigue, and even in higher risk MDS patients, differentiating two different Kaplan-Meier survival curves based on a fatigue score that's elevated in a higher risk patient versus not. Performance status, although in my experience, performance status is extremely crude. And if you look at the performance status in most registries, the majority fall into 0 to 1, and you have very few that are 2 or higher. Comorbidity, you guys all mentioned comorbidity as being important, and it doesn't really matter which comorbidity index you choose. There's multiple papers that would show that the consideration of comorbidity does add independent prognostic value to refine prognosis. And then we have also done a lot of work looking at frailty, whether or not you're using sort of a 1 to 9 Rockwood frailty scale or a sort of a continuous cumulative deficit frailty scale that we developed in our Canadian registry, that the frailty also can add up to 25% value into refining the prognosis. Are there any other prognostic factors that I listed that you can think of that are missing? And then I would love you to maybe comment on whether or not you pay attention to these other factors besides comorbidity in making your decisions about risk.
Rena.
Fact is, sorry.
Me? Okay. In terms of disease-related risk factors, among these you described beta-2 microglobulin, serum albumin, ferritin, and LDH. At least these are checked by Heinz when we developed IPSS-R. Some of those are clearly prognostic, and you can modify original IPSS-R score formula, including these factors. But the impact of those were less than the blast percentage, cytogenetic risk factor group, and also cytopenias. That's I remember. That's just my comment. Mm-hmm.
Mm-hmm. I mean, do you ever sort of go in and plug it into the formula? I know there is an online ability to do that. And I think one of the limitations why they sort of fell out of the final IPSS and IPSS-R is that it wasn't measured in everybody. So I guess their predictive power might have been diminished by the sample size.
Right. But after you calculate the score using the automated IPSS-R calculator, you can add some score plus or plus something. But that is only for overall survival, not for
Not for
leukemia
leukemia.
transforming.
Yeah, that's right. That's right. Silvia, you wanted to? Yeah, sorry.
Yeah.
Go ahead. Go ahead.
What happens sometimes, it's that even if we consider all these factors, sometimes the patient is not able to go to the transplant because he has some comorbidity that was not diagnosed before, even because he is a subclinical. Also, we had recently a patient with a severe pulmonary disease not diagnosed before. So even when we use all these known factors, sometimes we still have some contraindication for the transplant. So sometimes it seems to me that the patient have to be considering or are evaluated multidisciplinary.
Mm-hmm. If you're calculating somebody's risk score, though, in the clinic, let's say you've already established they're not an allo transplant candidate, but you have, for example, an intermediate IPSS-R intermediate risk patient. Let's say their score is 3, or it's not on the upper range of the intermediate category. When you're counseling your patient about what sort of expected prognosis is for them with regards to survival, not leukemia-free survival, do you attenuate your, if they're pushing you to, we don't always try to give numbers, but if somebody's pushing you or they've already read all about it on the internet, on Dr. Google, and they say, hey, this tells me my survival is 3 years, do you say, well, yes, except for example, you don't have any of these other negative prognostic factors, my expectation is that it's probably longer than 3 years. Do you ever sort of use these factors to I guess, modify what the expected prognosis is when in counseling your patients?
So my answer would be usually that the question is not how long the patient is expected to live, but can we improve the outcome? And that's the main question, actually. And that's a different question than how long will I live? And the question is whether intensive chemotherapy or transplantation is going to change his prognosis. And that's the question we are discussing right now, I believe.
Yeah, I think it's two things: is what can we do to change their outcome, but it also has to do, I think, with expectations of the patient and what to expect. When we're calculating prognostic factors, it's not just to decide what the treatment is to improve outcomes, but it's also for counseling our patients. At least that's how I see it too.
Mm-hmm.
Okay, let's go on to the next slide, because the kind of the elephant in the room really is the most topical and impactful elements right now, at least in the MDS field, is the incorporation of somatic molecular mutations on refining prognosis. And while it's not yet published, it has been presented a number of times, the IPSS-M. And I took the liberty of comparing and contrasting another prognostic scoring system algorithms to create a better prognostic score compared with the IPSS-R. And so just to compare the two, what I would call IPSS-Ms, one was derived from a very large sample size from the IMRA database, where they had clinical and molecular data. And the sample size was just shy of 3,000 patients. The IPSS-M from the Cleveland Clinic and the Munich Leukemia Laboratory was about half that size at 1,471. They both did validation of their prognostic scores. One was in Japan in 718 patients, and the Cleveland Clinic MLL IPSS-M validated in Moffitt cohort of 465 patients. More genes were sequenced and retained in the IPSS-M from the IMRA database, as you can see on the slide. Basically double the number of genes retained versus that from the Cleveland Clinic. And it may speak to the sample size from which they were able to derive the IPSS-M from the IMRA database. Both prognostic scoring systems incorporate the karyotype classification of the IPSS-R and retain it. But they don't retain anything else from the IPSS-R with regards to the categories of the IPSS-R. In the final model, there are 21 binary mutations that are independently prognostic, and in the IPSS-M from the Cleveland Clinic and MLL, there are 7. And then the mutation number is also of value in both of these prognostic scoring systems. In the IPSS-M, you have 17 residual distinct mutations. And in the IPSS-M from Cleveland Clinic, the number is also important, but they basically considered the number of all the mutations that were included in their modeling. So the number of elements that comprise the IPSS-M from the IMRA database are 4, which are bone marrow blasts continuously, platelet count continuously, hemoglobin continuously, not neutrophil count, and cytogenetics as defined by the IPSS-R. And what's overlapping in the IPSS-M from Cleveland Clinic are the same elements, but they also include absolute lymphocyte count, neutrophil count, monocyte count, the WHO classification, age, total white count, and the presence of peripheral blasts. There are 6 prognostic groups that emerge in the IPSS-M from the IMRA database. And whereas the IPSS-M Cleveland Clinic MLL is more personalized, where any individual patient will have what's their expected, leukemia-free survival and overall survival. Next slide. So the genes that are included in both models that overlap are highlighted in red. The usual actors, TP53. But it's only the multi-hit is considered important in the IPSS-M IMRA, whereas it's not sort of evaluated separately in the IPSS-M from the Cleveland Clinic. And we know that only two-thirds of patients will have biallelic inactivation. SF3 beta 1 being the only positive prognostic gene mutation, RUNX1, SRSF2 and ASXL1, and then there's a variety of other mutations that are considered in the IPSS-M over the Cleveland Clinic MLL IPSS-M. It's interesting that both models upstage about 1/3 of the patients. In the IPSS-M IMRA database, about 12% are downstaged, but we're not told in the publication in JCO how many are downstaged. And then the C index, which is sort of a measure of the goodness of fit of the model at predicting adverse outcomes. The IPSS-M IMRA has a 5-point increase for both overall and leukemia-free survival compared to the IPSS-R. And the IPSS-M Cleveland Clinic MLL has a C index increase of 7 points. Compared to the IPSS-R. So pretty similar, but graphically, I'll show you a figure that suggests that it's pretty impactful. Both of these, one more thing, the IPSS-M is for sort of to be calculated at diagnosis, whereas the paper from the JCO from Aziz Naza suggests that their prognostic score can be used dynamically. Although they don't really give us the data, they do say that they have proven it's valid dynamically. Both of these IPSS-Ms are agnostic to secondary MDS or the treatments received, and both will have an online calculator. Next slide. So this is the Aziz Naza paper that, you know, the panel A is the elements that predict that it's the same elements, but they're waiting for predicting survival in A, or leukemia-free survival in B are different. For example, bone marrow blasts is more important for predicting leukemia than cytogenetics is for, than it is for predicting overall survival, for example, where it's only kind of number 4. The C index for overall survival in C and leukemia-free survival in D in comparison with IPSS or IPSS-R, or even a previous publication that they had where they sort of added mutations just to the IPSS-R. It shows that the new model, either in the training or validation cohort, has a better goodness of fit. And then panel E figure shows what percentage of patients are upstaged or downstaged in purple and blue. And you can see that it's particularly relevant in the very low and intermediate risk categories, you know, how many patients are upstaged. And in the high and very high risk category, you can see that some of these patients are in fact downstaged. So, you know, that's kind of really important if you're, you know, planning therapy for your patients and deciding, do you need an allo transplant? Do you not? Do you need a hypermethylating agent? Do you not? You know, this is very important finding. Next slide. And then just click again, please. This is the IPSS-M that shows the 6 categories for prognosis and the nice separation in the leukemia-free and overall survival curves that were presented by Elsa Bernard at ASH last year. Next slide. And then this sort of online calculator that will be available, I am told, when the publication comes out, that will allow us to basically, you know, click on all the elements that's relevant to our patient and figure out which risk category they fall in with regards to predicting prognosis. So, you know, I'd like to open this up for discussion in terms of, you know, how you guys see the IPSS-M being deployed in your clinic. We know that not all these elements that are included in the IPSS-M are part of everybody's panel, gene panel. For example, MLL, PTD is not always included, and it also comprises a very small minority of your MDS patients as well. But the more missing elements, the more uncertainty there's going to be in predicting your patient's prognosis. So, and again, you know, I guess one of my concerns, I'm very happy with the IPSS-M and looking forward to using it, but one of my worries is it's kind of hard to know, and when you have 6 categories, you know, in the end, you want to know, do I need to offer you an allo transplant or not? Which is the risk, which is the dichotomous cut point where it tells me you need a transplant or not, if the patient is transplant eligible, or do you need an HMA or not, and so forth. So I'd love to hear your thoughts about how you're going to use these different IPSS-Ms that are available and the pitfalls that you see going forward. Theo?
Yeah.
Or Silvia?
Yeah, to begin with, I have a concern about the panel size, in fact, because it will be very, very hard for those low-income countries to put IPSS-M in the routine. Considering that not everyone has cytogenetics, you can imagine. So I think quite a few services will afford such a big panel.
Yeah, I do agree. Also in Europe, in the non-academic and referral centers, molecular analysis will be very rare. I also would like to warn against a new method of measuring it. It has to be validated in a prospective way, because it's very difficult to make a distinction between untreated patients and patients who receive effective treatment. So we do not know the predictive value of patients who have been treated with a certain specific intervention, like transplantation, like HMA and related, and so on, and also in the lower risk phase with luspatercept and ESA, and the transfusions are playing a role as well, the transfusion dependency. So I think we should be careful before we decide to focus too much on the new IPSS-M and related prospective prognostic schedules.
Yeah, those are really important points, and I agree with those concerns. Yasushi, what are your thoughts about using this?
In Japan, the genetic genome analysis for myelodysplastic syndrome is not yet covered by insurance. So in academic centers, we can do it as a part of research, but in general hospital, it is almost impossible, except for some very important genes like TP53 alone or SF3B1. Then probably for 1 or 2 years from now, many Japanese hematologists will use IPSS-R plus some genetic information, very small number of genetic abnormality like TP53 or something. And it is not yet easy to include whole genes listed here to include future coming genetic panel in Japan, because some are not very popular mutated gene in MDS. So as a research, it's very interesting and important. But considering the practical use of IPSS-M, we may need another version of practical version of IPSS-M.
Mm-hmm. So do you think perhaps the IPSS-M developed at the Cleveland Clinic with the MLL might be more easily deployable, fewer mutations that are being considered, easily measured other factors like the lymphocyte count and the monocyte count and so forth? Do you think that, assuming it's validated prospectively, as Theo has pointed out, do you see that as perhaps being a more practical, it's certainly considering more commonly mutated genes, right? That are more prevalent.
Right, but lymphocyte count, probably this is the first paper to show it's very important prognostic factor for MDS. We have used lymphocyte count to check the prognostic scoring system before, but we didn't find the impact of lymphocyte count, for example. This prognostic scoring system mixed not only disease-specific factors, but also patient factors like age. So a little bit complex system, I think. So as Theo said, we need prospective validation even for IPSS-M from Cleveland Clinic.
Mm-hmm. Yeah. The other thing I would point out is, while these prognostic scores improve on the IPSS-R by a little bit, they do improve the C index. They're not improving the C index to 0.9. That means there's a lot of missing information for refining, for sure survival. They might be better for leukemia-free survival, but But for overall survival, they're still missing almost 25% of what's going to be impacting other factors that are going to be impacting their survival, like, for example, comorbidity or performance status or frailty. And I think it highlights the importance of building these into our models, not just looking at the disease characteristics, but building these into our models so that we can better refine prognosis for our patients. And also perhaps predicting, even evaluating them in the context of clinical trials to evaluate the ability to tolerate the treatments that we're offering them, because sometimes these treatments are just too toxic for them based on their patient characteristics.
So if we expand those areas, in Japan, we also think about family opinion to decide transplant, not only patient's opinion, or the supporting situation by family members or caregivers to the patient. That's also an important factor to decide transplant. But those will not be included in a risk scoring system.
Okay, well, thank you very much for participating.